We started the company 15 years ago around the idea that healthcare is confusing and hard for the average guy to figure out. First person we went to meet said to us, oh, so you guys are going to fix healthcare and then you're going to be out of business. That was 15 years ago. Nobody's fixing healthcare, and business is great. So when you look at what's really going on, things are getting worse, not better. We've got 11,000 clients now. The slide says 10,000, but it's 11,000. We serve about, the service is always sold to you on the basis of a member or an employee per month basis, but it covers the employee, his or her spouse, their dependents, their parents, and their parents-in-law, which makes about 40 million people eligible to use Health Advocate. We got a lot of friends in this room, and we have a lot of services that we offer, and I don't want to insult or lose any of those friendships, but I do want to tell you what we do. So we serve many of the country's largest employers. We've got 11,000 employers as clients. About 600 of them are the largest companies in the country. That means that 10,400 of them aren't. I think our smallest company is a group of one. I don't really think that's a group, but we understand the issues that relate to small, middle, and large ends of the market. We have relationships with brokers all over the country who bring our services to their clients. We have relationships with Cypress that allows us to get in front of an audience and bring you a special relationship that we've created with them. That's how we get to the small end of the market. You know, we sell a service that sells for a buck or two per employee per month. You can't exactly go chasing a 10-life group in Dubuque. So you depend on somebody who can bring you there, and that's how we work with a lot of the distributor end of things. Healthcare is confusing and not getting any easier. We actually conceived of a company 15 years ago that would simply help people deal with healthcare problems. We answer the phone and we say, how can I help you? We never know what the next phone call is going to be about. If you come to us with an administrative issue, you talk to somebody that understands benefits. If you come to us with a health problem, you talk to a nurse. There's 7 full-time physicians. We've got nutritionists, social workers, wellness coaches, the whole gamut of things. But we divide our world into health issues and administrative issues. You can't, if you're not a nurse, you can't do health stuff. Nurses hate to do claims, so you gotta make that split. About 6 months after we started the company, we took a look backwards and said, okay, if we communicate to people that will help them with any kind of health issue, what kind of health issues do they bring to us? And we created this slide at that time. So life roughly breaks down into people that just need help finding care, understanding medications, getting second opinions. We schedule appointments. We help people understand the difference between different specialists. We help them in today's world look at in-network and out-of-network relationships. We try to drive them in-network. We talk to them about cost and quality, and we've got lots of tools about that. The other side of the business is the bills, the benefits, claims, grievances, all the paperwork stuff that gets in the way of somebody often after they've had care. And in today's world, there aren't 10 people outside of this room that understand reasonable and customary reimbursement. All right? So when you look at deductibles and coinsurance and limited networks, the world is going a little bit crazy, and business, I got to tell you, is better than ever. So the nuttier it gets out there, the better it is for us. But if you look at the things that we do, we primarily try to create a model in which we make everything else in the benefit package work better. So our role is to sit in the middle of whatever it is that the client, the employer offers, and string it together by putting somebody who understands the resources that are out there and the needs of the individual together. And when there isn't an obvious place for that case to go, we step in and do our own thing. So while we offer what we think is a great wellness program, and we do biometric screening across the country, and we have a nurse line and an EAP, and we play very nicely in the sandbox with everybody else. And you have to when you deal with especially the middle and large end of the market, because everybody's out there connecting themselves to best-in-breed relationships, and it doesn't help us to walk in and say, well, if you're going to use Health Advocate, you've got to use our EAP or our wellness program or our pricing tool. Or whatever. So we can make anything work. The key of what we do is to sit in the middle of that crazy patchwork of benefits and try to help an individual get to the right place at the right time, ask the right questions, get the right answers, and feel confident through that process that there's somebody there to help them. That's that advocacy role. Now, things are changing around us as we recognize. Today, 99.999% of every case we starts with a phone call. Somebody picks up the phone and says, help, all right? From the day we built the company, you could start a case by sending us an email. Almost nobody does. However, after that initial contact is made, about 75% of everything we do goes by email or text messages, something that is designed around the schedule and the means of communication selected by the person who needs our help. So we simply try to meet them where they want to be met. We've got this model that complements the things that are out there. So for, pricing transparency, real hot. We just heard a great presentation from the people at Blue Book, and we know them well. We have our own pricing tool. We love it. The thing that we do around pricing that distinguishes it is that we take you from what you see on your phone to actually getting care. I don't think anybody looks at their iPhone and says, gee, I need brain surgery. I wonder who's good, all right? I mean, it's not what's going on. But when you look at the phone and you say, gee, this is a doctor who looks like she's the person I want to go see to help me with my knee problem, the issue that comes up today is she still, well, first of all, is she still alive? Is she still practicing? Is she in my network? Does she have appointments? How do I get in touch with her? Where will she take me and what will it cost? All right? And those are questions that you don't get out of your phone. Those are questions you get by talking to somebody who will take the time, call the physician's office, and talk to that office, talk to the personnel there to say, look, I got a patient, it's a 400-pound diabetic, double amputee, and he's got a problem with his heart. How many of them have you done? All right, because I don't get anything that tells me that you've ever treated us. And if you're not the person that I want to treat that kind of patient, who do you know that is? Where would you take that kind of case? So it's all done very intensely. The typical case takes us 2 hours of discontinuous time that could be spent over a day or a week or a month or a year. Our longest case went on for 2.5 years. There was a little boy who was run over by a boat. He's fine, all right? But he's fined $3.5 million and 2.5 years later. So when you look at this, you get connected to somebody that's there to help you 24/7. You can come back to the same person, talk to them about your mom, talk to them about your kid. It's always the same connection, and that's what we play on, that idea of putting a person in the middle of your world to help you deal with the healthcare system. So we complement the idea of working around pricing transparency. I'll show you some other things about data. We are one of the largest biometric screening services in the country. If any of you aren't bringing the idea of running health fairs and doing simple biometric screening at the work site to your clients, you're missing the boat. All right? It's a tremendous opportunity to bring the concept of engaging individuals in health and wellness to the population in a captive environment where you not only can generate revenue for yourself, savings for the company, but build a certain sense of participation in individual health among that population. So biometric screening is a huge opportunity. We have a great wellness program. It's a wellness program. It starts with a health risk assessment. It goes through coaching. The key of it is that we can string it together inside our data environment, and we can take the information from the wellness program and bring it together with information from biometric screening, identify people at risk, and coach them through life events that can change the way that they get care in the system. So it starts hanging together, but we do a very good job working with other people's wellness programs as well. Everything we do is done within the concept of a HIPAA release that lets us be the individual in dealing with the healthcare systems. It is not a place where you come to say, okay, I got a problem, what do you want me to do? And we give you a list of 13 things that you should do. Well, you want to get into the mail order program, you need to get your doctor to write a 3-month prescription for that medication. No. We talk to you about things that we can help you accomplish, that we can do for you or with you, depending on what you want to do and how you want to participate in the system. So it's very much a hands-on, it's as close to the concept of concierge medicine as you can get without actually being face-to-face with the individual. At Christmas time and other holidays, people show up at the office with baskets of flowers that are sent from all over the country by people to their personal health advocate. We get over 100 unsolicited email compliments every week. So when you look at this, this is a service that people value and that provides value back, not only to the individual, but to the employer group. We do a very good job communicating the story to explain to people what it is that they can do. Okay. And in that world, we have a number of large clients, and those clients kind of offer everything. And you end up with a refrigerator magnet that's got 14 phone numbers on it. You know, this is the EAP, here's the workers' comp carrier, this is the disability number, here's the benefit administrator. Nobody can make sense of that, and I don't know about you, but my refrigerator is non-magnetic, so I can't hang anything on it. We offer a program we call Benefit Gateway. This is not rocket science, this is human triage. You simply give out one single 800 phone number, toll-free phone number, and that's the number to reach everything. So you want to talk to United Healthcare, you call 1-800-HEALTH-ADVOCATE. Oh, you want to talk to United Healthcare? We move the call to United Healthcare. You want to talk to somebody to enroll your new baby in your benefit program? You call 1-800-HEALTH-ADVOCATE. We transfer you over to Magellan, over to Fidelity or whoever it is. You want to talk to somebody about a behavioral health issue? We transfer you to Magellan. It's just triage. Now, I'll show you how we add value to that. But in and of itself, simplifying the means of access to programs is the single best thing you can do to improve participation in benefit selections. All right? The decision process of an individual. You want to remove as many barriers as you can for that person to access the kind of care and services that they need. So we thought it would be neat. I'll tell you how warped we are. So from the very beginning, we trained our staff to kind of look past the episode. So somebody calls because they have a question about a bill. Now, first of all, nobody ever calls us because the bills are right. All right? We don't get the call that says, hey, by the way, this bill is right. I don't know anything. Or they didn't send me a bill. I just want you to know about it. We don't get that call. All right? So when you look at our world, people call because they think something was done inappropriately or wrong. I don't care. Sometimes it is. More often than not, it's not. The usual problem is you don't understand your benefits, and that's pretty common. All right. But be that as it may, the only reason that you got that bill in the first place is because you received some kind of care. And for many people, that care is not one and done care. You know, so this is a bill for a cardiologist. Do you have a heart condition? And that leads us into a discussion of what are you doing for your heart condition, all right? So I thought it would be neat if we knew that about you before you told us, all right? So what if when you called us on the phone, regardless of what you called about, I knew you were a diabetic. And I know that there are certain things that diabetics are supposed to do to take care of themselves. They're supposed to have their eyes examined every year. They're supposed to have their urine checked every year. They're supposed to get a pneumonia vaccine. There are things that they are supposed to do. And if I knew that you hadn't done them, during the course of our discussion, I could drop a little hint to say, oh yeah, sure, we can take care of your mom. I know she's got, by the way, what are you doing for your blood sugar, all right? So I thought it would be neat if we knew that about you before you told us. And so to do that, we built a data subsidiary that we call Engage to Health. We take in medical claims, pharmacy claims information. We bring in results from biometric screening, personal health recorded information from a health risk assessment or a personal health assessment. We can bring in laboratory results. We blend it together into some proprietary algorithm. IT people love when I talk about what they do because I make it sound so easy. But we blend it together and shake it up, and it comes out. And it spits out to us a bunch of information that we can use. And I'm going to show you what we do with that. So the first thing that happens is that we create a dashboard for each individual member that we've got data on. which is virtually anybody covered for benefits by any of our self-funded employers. It's very difficult to get information from fully insured groups. But we can do it around self-funded groups, and we build out this profile of an individual. The key element for your purposes are the 2 spotlights that identify gaps in care or benefit opportunities that apply to this person. So now when that person calls in, the screen pops in front of our agent, and we're able to do whatever they want us to do, but we can prompt them to do something else as well based on what it is that the spotlight highlights. So in this case, this is an individual who's overweight, and there is a nutrition program that's sponsored by their employer, and we can connect them to that. So we take the little, it's what my mother used to call a nudge, all right? We just want to give them this little twist. If you call because you have a bill question, or you want to talk to Express Scripts about your prescription that you didn't receive, you do not want a 10-minute dissertation from me about the wonders of having a colonoscopy, all right? It just doesn't fit. But if I can tell you that there's a cancer test you need and that we can set up a time to talk about it, I can send you information about it. Is Tuesday good for you? Are you open at 3 o'clock? How about 7 at night after dinner? Let's have a conversation about something you might do. A very large percentage of people are interested in pursuing that. Why? Because they've called us. This is different from the call that you get over dinner, where the guy says, hey, put down the mashed potatoes, you're fat, and I'm going to make you healthier. Right? Nobody takes that call. All right? And if you've got messaging on your phone, you don't even pick it up in the first place. So it's different when you call me and say, help me, here's my problem, and I say to you, great, I'll fix that, and hey, by the way, you need a little something else. You need a flu shot, they're giving them Tuesday at the work site, and I can schedule that for you. Right? Whole different world of getting people to respond. So we use these dashboards in front of our agents at the time that an individual comes in. Well, if I can put it in front of our people, I can put it in front of the member. So every member gets access to this. It's basically the same dashboard. We dress it up with some tools and trackers and that kind of thing to make it a little more interesting for an individual. You can keep track of your weight, your height, your blood pressure, your blood sugar, whatever. But it's the same information. The key are the spotlights across the top that tell you that you're due for something, and the message is call Health Advocate, call your doctor, but get this done. Now, I have to tell you, we have an arrangement with Cypress for pricing of our services. The data dashboards that I'm talking about don't cost anything additional above that advocacy price that we gave them, all right? So give us data. I said to some guy, I said, all right, it's $2 per employee per month. He said, well, wait, what if I give you the data? I said, yeah, right, that'll make it $2 per employee per month. He said, well, what if I don't give you the data? I said, well, that's $2 per employee. It doesn't matter to us, all right? The data adds value to the dynamic. We want it. We don't charge you for it. We'll do it anyway, okay? So think about that. Now, the other leg of the stool is that we give each client their own dashboard. So think in terms of the ability to look at any period of time, a profile of the medical costs being spent inside the health benefit program. There basically are 8 charts that lay out medical costs. When you click on any chart, it ultimately opens 5 charts deep to drill down on the data. You can get down to the case, what was wrong with them, where they went, what it costs. You can look at the distribution of medications being used. You can look at who's in the ER, who's using the emergency room, who's using the inpatient side. We put this on the desk of the client. We also will put it on the desk with the client's permission of the broker. So you become consultative. The graphs are built on the monthly data feeds that we get. They show a rolling 12-month of information. So in January of 2016, January of 2015 drops off, in February, so you're always looking at the rolling 12 months, regardless of the plan year. That's important for something I'll tell you later. So I'll put it on your desk. You can get to it 24/7. In this case, the spotlights indicate the gaps in care or benefit opportunities that apply to the entire group. So if you were, they're typically arranged from left to right in terms of their magnitude of cost impact. So if you were working with this one group and you said to them, all right, we're going to create a strategy to look at your medical costs next year because they're really high, the number one place to go for this group is diabetes, because diabetes is the single largest driver of medical care costs for that group, because it's spotlight number one. The second place is emergency room visits. What can we do to get people to use urgent care centers or make sure they have primary care doctors or whatever? So the dashboards not only help the client, they help you become part of the discussion during the course of the year to identify trends that you can affect. Each of these, as I said, breaks down into multiple levels beyond that single dashboard. We can arrange them by division. Somebody's got an East Coast, West Coast deal. They've got hourly and they've got salaried workers. They've got blue collar, white collar, it doesn't matter. The way that you give us the data is the way that we give it back to you. And again, this comes along at no additional cost to you. When the clients do biometric screening with us, the biometric screening results flow right into the dashboard, and the data works its way into the risk assessment that drives the spotlights. All right? We also have a program where we take the same spotlights and convert them into letters. Dear Harry, you need a flu shot, all right? We call it personalized health communications. Every letter is unique to the individual, driven by their need off the spotlights. We can do the letters electronically, which brings down the costs. We can do them by mail. And interestingly, we've got lots of data that shows that people actually read the mail. So I'm not going to go through all that, but we do. All right, so I told you that all the dashboard charts are rolling 12 months. But every client gets an annual report that summarizes their plan year. So they give us their data, and we've got to analyze the data to build out the dashboard. It becomes, here's what we're starting from. We call that the baseline medical claims assessment or analysis, and we give it back to the client. It's a 60-page report. It matches anything you get from Truven or Ingenix or anybody else. And it tells you this is what happened last year. Then at the end of this plan year, we give you the same report comparing the 2 years together. And that gives you the opportunity to measure the effectiveness of any of the programs that you've put in place. So you get this breakdown of medical costs in a comparative way, looking year over year, and in some cases looking at national benchmarks, for example, in preventive care, so that you can compare where you are to what the national standards are. So this is all data-driven information that makes us, we think, provide a distinguishing type of advocacy service at the level of understanding of the client so that they can make reasonable decisions with your help and guidance as they look at their opportunities to affect the way individuals covered for their benefits get care. We talked about, real quickly, we have a mobile app. It uses the same data. We're sitting here about now 3.5 years ago, and the world explodes with people that are looking at pricing transparency. And we've got all the same data that you need to build out pricing transparency tools. So we've built out what we think is a highly competitive, extremely cost-effective pricing transparency application as well that does all the things that pricing transparency applications are supposed to do. We bring in quality health information, we bring in cost of care information, we can set you up with demos so that you can muck around with this on the internet and play with it to your heart's content. So I'm not going to spend too much time. We just had a whole bunch of presentations about that. The other thing that we're able to do is use data to identify, obviously, who's doing what. It's the same as, it's the same information if you're smart enough to know how to slice it and dice it. And so in today's world, we're doing a lot of work with large employers, TPAs, a couple of brokers, and several health plans where we're helping them build out the idea of the high-performance network that they're selling. People are very interested in identifying people who do things better and at lower cost, and creating, as you know, narrow networks, which drive users crazy, but at the same time, we have the ability to use that data. This harkens back to my old world where we were doing the same kind of information inside the health plan as we tried to profile physicians to understand who was doing what, and more importantly, to look at how you can affect change inside the provider community. We can also customize the dashboard around unique needs we get into data analytics for the sake of data analytics. You know, when an individual company gives us their data and signs up for our dashboard environment, they get the standard dashboards that we create. And yes, there are about 125 different reports that you can drive out of the dashboard, and somebody always wants the 126th one. So we build out customized versions of these dashboards, but I'll tell you, as much as we love selling data analytics services, the truth of the matter is that lots of people think they want a lot more information than they'll ever use in their lifetime. And what I encourage them to do is run with our standard dashboards, see what it does over the course of the year, and then develop what you'd like to see that might be different, and we can price that customization out for you. But yeah, we can create this is actually an underwriting dashboard that we built for Aetna around their small groups that identifies risks within the groups, looks at things like cost trends in terms of is the group getting more risky or less risky, more expensive or less expensive, based on who leaves the group during the course of the year. So you start out at one point in a small group of 400, and they have turnover of 50 employees. Were they 50 inexpensive employees, or were they 50 expensive employees? So what the group looked like then may not be what the group looks like now. So we can do that kind of analysis for them. For every group, we do this risk analysis that brings in a picture of where the group falls, relatively speaking, in terms of future risk. Future risk means the likelihood of individuals needing medical services over the course of the year that are unusual and unexpected. So it's not preventive care. It also, it's driven a lot by maternity costs and by unanticipated and illnesses that can't be widely influenced, cancer, transplants, those kinds of things. But it eliminates the one and dones. So if you have a terrible circumstance, you get injured, you break every bone in your body, and you're expensive this year, you don't really represent a high risk for recurrence next year, because it's unlikely that you're going to fall off the same roof and break every bone in your body again next year. So it's a risk assessment that becomes of value in looking at things going forward. And we've got very good data on correlating that risk with the likelihood of increased medical costs in the year to come. Finally, the last step of the stool was to look at people that have these ongoing and chronic conditions that tend to drive costs. You know, we were sitting looking at the data, and the truth of the matter is that there are large numbers of people who have chronic conditions and can be helped just fine if you identify them and intervene with them to get the kind of routine care that those people need that's identified by the dashboards. So again, kind of selling against myself, I tell our clients, if you're thinking of disease management as an adventure, run with the dashboards. Because simply by identifying gaps in care associated with individuals that have health needs, diabetics who need their eyes examined, asthmatics that are not refilling their prescriptions, people with heart failure that are not on beta blockers, if you simply run with that and try to influence them across our dashboards, which have no added cost, you'll probably get yourself 90% of the way to everything you can accomplish from disease management. And then if you want to focus on the most seriously ill and non-conforming part of the population, you can apply a specific program to them. We call that program chronic condition management. Now, the thing I have to tell you that's so important to realize is that around you, the healthcare dynamic is changing. Physicians are increasingly being paid based on the quality of care they provide and their ability to care for that patient in a holistic manner. And in many cases, they are at risk financially for the outcomes of those individuals. So in this day and age, the last thing you want to do is try to extract that patient from that physician's care and put them in a standalone disease management program. The intent of our program is to provide education to the individual who's got a chronic condition and connect them back to their physician. Be there for them in the future if there's ever an issue that comes up, but get out of the way. This business of, back in when I was younger, I ran the largest disease management program in the country. And I used to let people used to say to us, how many of the diabetics can you find? We find all of them. We're paying the bills. I mean, if you're taking insulin, you're a diabetic. This is not rocket science, right? Although we could always seem to find people who had 3 years of getting an insulin prescription refilled every month who swore they weren't diabetic. I don't know what they were doing. Maybe the dog was diabetic. I don't know. But that's never been the challenge. The challenge is, how do you affect the way those people get care? Well, for most of them, the best way is to connect them to a physician. And in this world today, physicians are increasingly being provided with an incentive to assume responsibility for that care. So one of the things shifting about our model is that we are increasingly working directly with physician groups to provide health advocacy inside the physician group itself, where we can apply the services to the membership, in this case, the patients in the practice, or the accountable care organization, or the patient-centered medical home. But the model that used to have people in these everlasting disease management programs that just went on for years and years and had no connection to what was actually going on in the world are dead. They're just simply passé. So our goal is to find individuals who are the most severely ill and non-compliant, try to work with them to educate them and connect them to a physician, and then keep in touch with them to make sure that that relationship is working. And when we do that, we end up in the best situation. So again, I come back to, how do you change utilization into engagement? Well, we do it by trying to drive more people through our pipe. Because if I can get you to call, that story about the refrigerator magnet, if I can give you 1-800 number to call, we will simply move the call where it belongs if it doesn't belong to us. However, for every case, we drop the dashboard. And so you call in and say, hi, I want to talk to Fidelity because I got to enroll my baby in my benefits. And we get the chance to say, oh, you had a new baby? You ought to get a Tdap, which is the adult pertussis whooping cough vaccine. You ought to get a Tdap because that's the vaccine recommended for every new parent and grandparent when a new baby comes home so they don't get whooping cough. And we can help you do that. So we get the opportunity to change every interface into the potential of a health discussion. And that's really how you distort the healthcare system going forward. We interestingly have a number of clients now, about 40, who buy lots of stuff from us. So they buy our advocacy piece, they've got our data, they've got our wellness program, they've got all kinds of art stuff. And for them, we create a unit that we call the Empowered Health Unit, where literally we bring together all those resources under one little umbrella and sit the wellness coach beside the advocate, beside the nurse, beside the EAP counselor. So that we can create an environment in which the individual no longer has to think about, who should I call? All they have to do is make contact, and we'll get them into the right area for whatever help they need. That's what we're doing. We have a brand new relationship with Tom and the people at Cypress, and we love it. And we'd be happy to answer any questions, and look forward to working with all of you.